Hello, everyone. Just another couple of minutes as we let more people into the meeting. Welcome. Looks like we have a critical mass, so I'm going to go ahead and start. Good morning, good afternoon, good evening, wherever in the world you may be. My name is Arzum Chilolo, and I'm the team leader for Breakthrough ACTION Zambia. Welcome to our end of project celebration. We're so pleased that all of you are able to join us today to hear about the successes of Breakthrough ACTION Zambia over the last 3 years. We would have loved to have had this event in person in beautiful Lusaka, but perhaps it's a blessing that many of you that we're having this event virtually, as many more of you are able to join us than would have if we'd been in country. From 2017 to 2020, Breakthrough Action, made possible by USAID and the generous support of the American people, worked hand in hand with the Zambian Ministry of Health and its Department of Health Promotion, Environment, and Social Determinants in using social and behavior change to promote healthy behavior in the areas of family planning, malaria, HIV, maternal child health, and nutrition. Our successes are the result of the strong partnerships between the Johns Hopkins Center for Communication Programs and Ideas 42, Save the Children, Think Place, and Viamo. I'd also like to recognize the strong managerial, technical, and administrative teams of Breakthrough Action Zambia based in Lusaka, the provinces and districts where we worked, as well as the US-based team. Your dedication, hard work, and commitment were the key to the success of our project. Today's event will present our key activities and highlight our accomplishments. The Breakthrough Action team will also share lessons learned from over the course of the project. So here's a quick look at today's agenda. After our opening remarks, we'll hear about the details of the innovations designed and implemented by Breakthrough Action Zambia. These will be followed by presentations on the quantitative results of a mini survey conducted by Breakthrough Action Zambia and the qualitative evaluation by our sister project, Breakthrough Research. We'll then hear some of the voices from our partners in the field. We'll include time for questions throughout the different sections of the agenda, but please feel free to add questions to the chat box that we'll be monitoring, and we'll be sure to address those when we can. Once again, welcome. And now I'd like to introduce Dr. Abel Caballo, the Director of the Department of Health Promotion, Environment, and Social Determinants of the Zambian Ministry of Health, for his opening remarks. I'll just take a second for us to bring that up.
On behalf of Ministry of Health and indeed the Republic of Zambia, I would like to pay special gratitude to the American people, Breakthrough Action Zambia, for the support that they've given the Ministry of Health and indeed my department in particular. You are aware that stakeholder collaboration is very, very important in implementing health promotion activities, especially in resource-limited countries like Zambia. And in this, we found a partner in Breakthrough Action, who partnered with us in implementing a number of health promotion activities that has made us actually reach quite a lot of milestones. Among us achievements that we have with the collaboration with Breakthrough Action, we have strengthened capacity to implement quality social behavioral change programs. Ministry of Health and our strategic government departments have been trained in leadership and governance. This training has not only trained policy makers, but it has gone to the level of directors, assistant directors, community members, sub-national level staff, up to the level of the household. They've been trained in leadership. Hopkins Center for Communication Programs, and indeed Breakthrough Action. And we are pledging to say that the programs that we've instituted and we've started with, this support are going to be sustained for the benefit of our population and for us to attain our vision 2030 of an emancipated Zambia, which is economically viable, being driven by healthy and productive people. Thank you so much.
Thank you to Dr. Caballo. And now I'd like to introduce the Breakthrough ACTION Zambia Chief of Party, Ms. Chime Mkwakwa, and she will give some remarks and overview. Chime?
Hello, everyone. I'm giving a breakthrough overview. BA is
There's a bit of an echo, Chime.
Sorry?
There's a bit of an echo. If there's another computer in the room, maybe you can mute one of them.
Okay. Yeah. We'll do that right away. Okay. So Breakthrough Action is a 3-year integrated social and behavior change project funded by USAID. Can I have the first slide, please? Okay, the next one. Next slide. Okay, these are our partners. Next slide. Overall goal of BA Zambia is to improve health outcomes among Zambians through increased adoption and maintenance of priority behaviors. And the project's focus is on 5 technical areas, as you can see them listed. Next. The project focused on 5, although the project focused on 5 technical areas, the project focused on 6 priority behaviors. Next. Breakthrough Action Zambia has been implemented in 4 provinces and in 9 districts. Next. I think it is really not surprising, as a social and behavior change project, implementation focus was at facility and their catchment areas. From this slide, you can see that in year 3, we had an increase of more than 50% facilities. And whilst other provinces had only 2 districts, Copperbelt province had 3 districts, with Kalulushi having 5 facilities compared to the other districts, and Ndola having 2 facilities. Next. The project guiding principles included participatory planning and implementation, designing low-cost and replicable interventions, partnering with implementing partners, and these are partners that are working in the BA provinces and BA districts, strengthening and utilizing existing structures at various levels of service delivery. Next. As was expected during year 1, BA project designed low-cost and replicable innovations. Included in the innovations are the Men's Wellness Days, Adolescent Wellness Days, NIZI, this is a confidentiality agreement, Growth Monitoring Toolkit, Emergence Plan Prompt, Provider, Behavior Change, and from the next slides from my colleagues, they are actually going to expand on this in the next set of presentations. Thank you.
Thank you, Chime. And now it's my pleasure to introduce to you Ms. Heidi Obra, and she is the Director of the USAID Health Office in Zambia. Heidi?
Thank you. Good afternoon, good morning, wherever you are in the world. Director of the National Malaria Elimination Center, Dr. Mutinta Mudenda, Provincial Health Officers, District Health Officers and Health Promotion Officers, Chief of Party, Breakthrough Action, Ms. Chime Mukwakwa, representatives from Johns Hopkins University, representatives from USAID implementing partners. Good afternoon, ladies and gentlemen. On behalf of the United States Agency for International Development, it's my pleasure to join you for Breakthrough Action's End of Project event. I want to begin by acknowledging the team for their hard work and commitment over the past 3 years. At USAID, we recognize that it is not often enough to invest in health services and products to improve health outcomes. Social behavior change interventions play an important role in addressing the knowledge, norms, and attitudes that drive health-seeking behavior. At the start of Breakthrough Action activity, USAID worked closely with the project team to identify priority areas for behavior change interventions. These included family planning for adolescents, condom use, timely care seeking for children under 5, HIV testing, complementary feeding for children under 2, and use of bed nets to prevent malaria. Once these focal areas were identified, the Breakthrough team committed themselves to an impressive formative research process to inform program design. USAID is proud to have partnered with the Breakthrough Action team, and we congratulate you on your many achievements. With the introduction of the Wellness Day model, Breakthrough Action focused on promoting overall health and well-being through integrated delivery of services, including family health, nutrition, HIV testing, and general health checks. Targeting men and adolescents, Breakthrough worked with health facility staff to increase care seeking for key services amongst these hard-to-reach populations. During the project period, Breakthrough supported 266 wellness days and served a total of 12,608 adolescents and over 10,000 men. I would also like to highlight the impressive design and rollout of Breakthrough's growth monitoring kits. These kits, which included a chart to measure the growth of children, a pictorial guide with information about nutritious and appropriate foods, and a feeding bowl to promote complementary feeding for children under 2. Working with USAID partner Expanded Church Response, 8,461 kits were distributed for use by health workers and mothers. Finally, I would like to recognize the Breakthrough team for their commitment to SBC innovations. These include the development of a household-level strategy for caregivers to seek immediate care for a child in an emergency, and the NIZI model, which promotes provider confidentiality to reduce barriers to care seeking. Considering all of Breakthrough's accomplishments, I am most impressed by their commitment at each project stage to improving the capacity of Zambian institutions to fund, coordinate, design, implement, and evaluate effective SBC programming. Since the start of the project, Breakthrough has worked closely with the Government of Zambia partners at the national and subnational level. At the national level, these include the Directorate of Health Promotion, Environment, and Social Determinants, the Department of Community Health, the National AIDS Council, the National Malaria Elimination Center, and the Food and Nutrition Commission. At the community level, Breakthrough's interventions were always delivered in partnership with health facilities and staff, community health workers and volunteers, and neighborhood health committees. Breakthrough's development of a how-to intervention package, which includes implementation instructions, costs, logistics, and materials templates, will allow Government of Zambia's partners to sustain interventions well into the future. We look forward to learning more about this package today, along with Breakthrough's many other achievements. Our thanks to the Breakthrough team for a successful project, and we wish you all the best. Thank you.
Thank you so much, Heidi. Thank you for the kind words. So now we'd like to move on to our session that will discuss these innovations that Heidi mentioned. And it's my true pleasure to introduce to you Mr. Fayaz Khan, who is the Deputy Chief of Party of Breakthrough ACTION Zambia. Fayaz?
Thank you very much, Zoom. And thank you very much for joining us, and good morning, good evening, good afternoon, everybody. As my Chief of Party, Chime, shared with us the salient features of our project, I'll quickly go through some of these and we'll try to make sure that we understand them in the right context. And if you have any questions, we'll be more than happy to respond to them. So Chime shared that Breakthrough Action's objectives and 6 key behaviors that the project has at its focus. And also the criterion that worked for us when we started developing these innovations. Breakthrough Action set up a simple 3-pronged criteria for proposing and scaling up its interventions. And this criteria was actually, can you see my next slide?
No.
Okay.
Oh, yes, now we can.
Okay, thank you very much. The first of this, which we can call the trifecta for innovation, was the desirability. That the proposed solution has to be something that the stakeholders and users actually need. It solves a problem and it serves a purpose. The second criterion was that the solution or the innovation can be done in given circumstances and within the system's strengths or limitations. So proposing something which was, which will require building new infrastructure or bringing in new team players or building new things and required a lot of logistics was something that was beyond the scope of our project. The third point for which the project was really concerned was that the innovations have to be viable and could be sustained with their intervention. So if the project withdraws, and since the focus was on implementing partners, they should be able to implement those interventions with minimum resources, and that would be continued. So any innovation that ticked all 3 of this criteria was considered for scaling up. Those that did not were rejected, and some of them were really good, but we could not go with them. To cope up with the challenges, Breakthrough Action came up with this new SPC model, and Zambia Breakthrough Action was the first, one of the first to implement it. That gave us the flexibility to use new knowledge and disciplines from the field that included human-centered design, behavioral economics, along with community engagement and behavior change communication. The new SPC model, as we call it, the SPC flowchart, has 3 distinct phases. Number 1, define. Number 2, design and test. And number 3, apply. And I'll quickly explain these phases with reference to our interventions for easy reference. The first phase of the SPC flowchart, define, looks at the problem through the lens of the data, context, content, for example, desk review, stakeholder mapping, etc., which led us in identifying and understanding any gaps in the available information, and based on which formative research was designed and carried out. The results helps us along with stakeholders in generating insights that led us to the second stage of the SBC flowchart, designing and testing and prototyping. At this stage, areas were also identified for further research so that in the next phase project could understand those issues better. Now, the project was a 3-year intervention. So using the SBC flowchart, the project in year 1 designed and tested 8 prototypes. 4 of them were rejected, as despite being promising and desirable, they did not tick the other 2 criteria of feasibility and viability. We therefore selected 4 prototypes along with an umbrella campaign so that everything syncs together and there is no audience fatigue as far as the messages are concerned. In the second year of the project, 3 additional prototypes were finalized. I am, however, going to talk about only the first 4 prototypes in the next few slides, as my colleague Salome will discuss the family health campaign and Lydia will brief you on the 3 innovations of year 2 of Breakthrough Action Project. So after testing and selecting of prototypes, the third phase of the flowchart, which I shared with you, is implementing them in the field, tweaking them and coming up with the final innovation with numbers and results so that stakeholders can see. The next slides are focused, therefore, on the 4 prototypes, including Adolescent Wellness Day, Men's Wellness Day, NIZI, and the Growth Monitoring Chart. So based on the findings of the SPC flowchart, the first phase of define, the project for the first area of adolescent family planning had identified a number of barriers that discourage adolescents from getting services at clinics. Some of these barriers are listed here as highlighted by our research. Adolescents do not seek family planning or condoms from health facilities due to concerns about privacy and confidentiality. Adolescent girls do not use family planning because social norms dictate that it is unacceptable for unmarried people to use contraceptives. Adolescent girls do not use modern contraceptives other than condoms due to the fear of side effects. Adolescent girls have misconceptions about family planning. They believe many methods can cause infertility. And on ITNs, adolescents also had misconceptions. For example, they thought that ITNs could have side effects, and some of them were very serious, like impotency and infertility. And also, adolescents do not use family planning ITNs because they or their family members perceive adolescents to be at the lower risk. So these were key barriers that we identified and tried to address them. These barriers, which look too many, through the project's simple intervention called Adolescent Wellness Day. This intervention was based on the understanding of the problem of the image of the health facilities. So we realized that adolescents did not want to walk into the health facility for the fear of being reported to their parents that X and Y was seen at health facilities, so there must be something wrong, or a host of other concerns about privacy, being judged by the providers, being scolded by providers, etc., etc. So we made walking into health clinics through this intervention as a social norm by announcing it in public and involving the entire community in organizing it to encourage adolescents to attend the wellness day to get tips for healthy living, safeguarding against diseases, etc. So you can see on the side, this slide, that Adolescent Wellness Day was basically dedicated health and wellness day organized every 2 months at a health facility where adolescents could seek services discreetly, including family planning, HIV testing, malaria. So public announcements will go in a community, schools will be involved, parents will be involved to just announce that on such and such day, a health day will be organized. Providers will use toolkits to systematically discuss various health topics during individual checkups. And adolescents, after the consultation, will get a take-home package, including condoms and an advice sheet with key health messages. So this was a very simple, straightforward innovation. The results were really encouraging. The same health facilities, which will see a few adolescents in a month, saw them lining up, sometimes in some places in hundreds, outside health facilities, and also being encouraged by teachers, parents, and village heads to do so. So in a span of around 10 and a half months that this intervention was implemented before COVID-19 halted our field activities, we had organized 130 adolescent wellness days, which were attended by 12,608 adolescents, girls and boys. 5,000 plus were screened for malaria, 4,000 plus were tested for HIV, 5,000 plus counseled on family planning, and 580 accepted new modern family planning methods. Now, analyzing barriers for men, who was another key audience for this project, to access health services, including HIV testing and treatment, family planning, and malaria, we found that men do not access condoms or HIV testing at health facilities due to concerns for privacy and confidentiality. Men prioritize their children's or families' use of an ITN over their own because they believe they are at low risk of malaria. And men value the health of their families, but view their role as providing financially for family rather than becoming involved in decision making. To overcome these barriers, the intervention of holding specific wellness day, just like the Adolescent Wellness Day, was for men. And it was also based on the realization of the problem of the image of health centers, which are known or seen as sickness care centers rather than wellness centers. And men do not want to walk into a sickness care center to show that they are weak or sick until they are really, really very sick. As one health center in charge put it while talking to me, was that I see men in my clinic mostly in two conditions. Number one, when they bring somebody who is unable to walk, or number two, when they are brought here because they cannot walk. So we did not change anything except the branding of our intervention, describing them as wellness days rather than, testing days or, malaria days or something. So Men's Wellness Day, again, is a dedicated monthly health and wellness day for men aged 20 to 55 to receive services such as HIV testing, condom provision, information on ITN, family planning, nutrition, exercise, fitness, etc. PA announcements, village chiefs and neighborhood committees will be involved to announce these days. Providers will use toolkits to systematically assess health issues, and men will receive services, and when they are going back, they will also have a package which will have an advice sheet and condoms. This was Wellness Day, and the results. 135 Men's Wellness Day were organized during the period of intervention. 10,434 men attended them, and 5,000 were screened for malaria, 4,000 tested for HIV, and 4,798 counseled on family planning. Am I going all right? Am I slow, fast?
You're perfect, Fayez. And in the meanwhile, if anyone has any questions, please put them in the chat box.
Yes, if there are difficult questions, our Zoom will definitely respond to them. The third area of intervention for the project was confidentiality, as has already been shared through previous slides, that both for men and adolescent, privacy and confidentiality has been a big concern. You can see that men do not access condom or HIV testing at health facilities due to concerns about privacy and confidentiality. Adolescents do not seek family planning or condoms from health centers due to concerns. So for both, privacy was an issue. So in order to address this concern, the project designed a new intervention, which was part of the overall Wellness Days package, and we refer to it as NIZI. So NIZI is a comprehensive strategy in health facilities to encourage providers to value and maintain clients' privacy. Health workers receive reorientation on how to maintain privacy and how to value it. Providers would sign a pledge promising to maintain confidentiality. And those who sign this pledge also get a badge, NIZI, which means confidentiality or between us. A pop-up display lists 3 promises that a client and a provider will make to make sure that they are open to each other and are able to, and the provider is able to respect the confidentiality of the client. All facilities where wellness days were offered also had NISI training, and providers signed an agreement. And so far in the project trained 5,035 health providers were trained, who during the wellness days, 22,147 people they provided the services to. But these providers were also the providers who would serve the clients on other normal days besides the wellness days. So around 600,000 population benefit from this intervention of NISI alone, because the providers will always be there 24/7 at the health services. Now, coming up to the 4th intervention, which was focused on child nutrition and growth, our insights and research showed that mothers do not consider diversifying the type of foods they feed young children because they feel they are feeding their children appropriate foods. Mothers do not see the need to change the amount of frequency of the food. And mothers do not see a need to change their behavior because the gap between the child's nutrition and optimal nutrition is not observable. So based on these insights, project came up with an intervention which we started calling as growth monitoring toolkit. It is a simple intervention of enabling caregivers to track their child's growth and help them understand the optimal child feeding practices. So community volunteers deliver a growth monitoring chart to families and also teach them how to measure their children against it. Then a pictorial guideline, which contains explanation on how the chart works and what to do in case the child is stunted, is also given to the parents, and they are oriented on it. Then families receive a designated feeding bowl. This is just an ordinary feeding bowl for each child, which helps them to understand how much child has eaten at each meal time. So the project has trained 1,119 health providers and community-based volunteers on this chart. 10,222 caregivers of children under 2 were oriented on this, and the same number of charts have been distributed by the project to the intended audiences. When we come to some of the successes of the project, the wellness days have managed to attract men and adolescents to the health facilities with an average client load of around 105. Dr. Abel Caballo, who is the director of the Directorate of Health Promotion, when he visited one of the wellness days, he came up with these remarks: "What have you done to bring these many men to the clinics?" He was really surprised and was very, very happy as well. Then there is another quote that I have been working here for the past, this was a health facility in charge in Mchinchi Health Center, Chingola, who said, "I have been here working for the past many years, but I have never seen so many male clients at my clinic on a day." Now, due to their perceived benefits, headmen, family members, and teachers encouraged men and adolescents to attend these days. Both providers and client expressed that NISI program has allowed clients to be more open about their health. And some partners have already started taking up project innovations for further implementation. This includes ECR for GMT kit and Latkins for adolescent wellness days. And there has been a number of them once the project stopped organizing them. I would just like to end my presentation on a very small message from a youth icon, Lizzie, who had been one of the promoters for young girls to protect themselves against unintended pregnancies and HIV. And I will just play this.
I love singing. I love making music that speaks to my soul. And mostly, I love life. Hi, my name is Wezi Victoria Muhone. To become an award-winning Zambian musician, I practice and improve my music every day. I also practice having safe sex. I'm careful and I make sure I practice having safe sex with my partner by using a condom. Not only are they used to help protect against sexually transmitted infections, they also help prevent unintended pregnancies. This isn't about love or feelings you have for someone. It's about life, your life. If you want to reach your dreams, then protect yourself. Protect yourself by using a condom every time you have sex. Remember, life is precious. Take care of it.
For more information, follow our Facebook page, Life is Precious Zambia. Yeah.
Life is a precious seed. Take care of it.
With this, my presentation ends. Thank you very much, ladies and gentlemen, for being such a wonderful audience. Over to our Zoom back. Or should I introduce Salome? I think I can, unless there are, our Zoom, should we take questions or should I go to Salome?
Oh, it looks like someone does have their hand raised.
Okay.
So we can allow Mary to speak.
Mary, you're unmuted right now.
Please go ahead with your question.
You might click the microphone.
I just want to say that the chat box is not working for me. I don't know if it's the same for everybody. I'm not able to put something in chat. I normally would do that rather than raise my hand.
Okay, we'll see what we can do about that. Do you have a question?
Well, I did.
Please go ahead.
Oh, okay. Thank you. I wanted to, I think that this is amazing. The process indicators that you've shown there have been fantastic. These outputs. It was quite a fairly short time that this has been working, but already you should be able to get some outcome indicators. I would think teenage pregnancies, stunting, underweight, maybe not stunting, but underweight, HIV incidence in these age groups, malaria in the clinics. Were you able to link those up with these outputs that you've included?
Thank you very much, Mary. Outcome indicators, I am not sure because as you have mentioned, it's a 3-year project, and the intervention was for a very short time, and then everything else was halted, including one of our baseline, one of our surveys to understand, how the interventions have gone. So that survey was shelved because of the COVID situation. However, we have some evidence that showed that how the interventions were implemented, how they were received, and some preliminary results which will be presented in the section which is talking about the surveys and evaluation of the project.
Thank you, Fayez. If you have other questions, I think the chat should be working now. In the meanwhile, would you like to go ahead and introduce Salome, Fayez?
Yes, definitely. So ladies and gentlemen, it's my pleasure now to introduce my colleague, Salome Timba. She's a senior program officer working with Breakthrough Action, and I had the pleasure of working with her. She'll be sharing with us the family health campaign, what was this and how it unfolded and how it supported the entire project. So Salome, over to you.
Thank you, Fayez. Good morning and good afternoon, wherever you're joining us from. It's a pleasure to be with you this afternoon. So as Fayez indicated, I'll be talking about the National Family Health Campaign, which was part of our support to the Ministry of Health. Justin, we can go to the first slide. So Zambia's Ministry of Health has been implementing the transformation agenda, which is basically a health service delivery model that places more emphasis on preventive health services. So this agenda has been ongoing since 2017, and it's a paradigm shift for the Ministry of Health to focus more on preventive health services. And what this meant was that there was need to create an enabling environment for Zambians to adopt and maintain positive social norms around health. So part of our support as Breakthrough ACTION Zambia to the Ministry of Health was launching and implementing this campaign, family health campaign under the theme, Life is Precious, Take Care of It. Next slide. So the National Family Health Campaign is basically an overarching umbrella campaign whose objective is to create synergies to avoid message fatigue and provide simple steps that families can take to live healthy lives. So this campaign can be simplified in the following 3 steps. Firstly, it's a national inspirational brand that's produced and launched by the Ministry of Health. And then this brand identity is promoted extensively to make it resonate with people's feelings and bring different activities under one fold. Thirdly, the National Health Campaign brand becomes a tagline with all mass media, local media, and community level activities to create synergies. Next slide. So this campaign, the National Family Health Campaign, was implemented at national and local levels, and it leveraged different platforms. And among the campaign activities, we had radio spots and talk shows. We had video testimonials. We had social media presence through Facebook, WhatsApp, and Twitter. We had posters and pamphlets that were produced. We conducted roadshows as well as community engagement activities. Next slide. So the results of the Family Health Campaign are as follows. We produced 20 radio spots that were broadcast over 35,000 times on national and community radio stations. We were able to conduct 23 roadshows in project districts. We also collaborated with the Ministry of General Education, Ministry of Health at local level, as well as district administration offices in our project districts to conduct 8 football tournaments, which targeted in and out of school adolescents. We were also able to create a network of religious leaders that included 211 religious leaders that were engaged, oriented on the family health campaign, and encouraged to support community members to seek health services at the local facility. Under the campaign, we were also able to conduct 151 rounds of public address announcements in all the project districts. Next slide, please. So in terms of our social media platform or social media presence for the Family Health Campaign, on Facebook, we had more than 30,000 followers, and the video content that was shared through Facebook received more than about 1 million views for all the video content that was shared through Facebook. On WhatsApp, we were able to create eight groups for religious leaders. This is for the 211 religious leaders network. So 8 groups were created on WhatsApp for religious leaders and 6 groups for adolescents that had accessed wellness activities at the local facility. So we created 6 WhatsApp groups for adolescents. Then our Twitter account for the Family Health Campaign had over 1,000 followers. Next slide. Then in terms of materials production for the campaign, we developed and distributed 95,000 copies of 12 different posters. We produced 10,000 comic books on adolescent family planning. We printed and distributed 15,000 malaria job aids for community-based volunteers. We produced and distributed over 12,000 emergency planning prompts for children under 5. We also distributed over 8,000 growth monitoring toolkits. Also included among the materials that we produced were 9,000 copies of the National HIV and AIDS Communications and Advocacy Strategy, as well as the production of campaign materials to increase visibility of the projects. So these included t-shirts, wristbands, and Caretakers. Next slide. So as part of the campaign, we also conducted project closeout activities. So among these were the production and the development and production of closeout packages, which are basically guides on how to implement the different interventions, the different project interventions. So among these, we had how-to guides on wellness days, on growth monitoring toolkits, on the NIZI confidentiality pledge. We had how-to guides developed on emergency planning prompt, provider behavior change, as well as the family health campaign. And also as part of closeout activities, we have in this webinar as well. Next slide. So that's basically it from me. Thank you very much.
Thank you so much, Salome.
Okay.
Great presentation.
Thank you. I will now turn to introduce Lydia Troop, the Innovations Advisor for Breakthrough ACTION Zambia.
Thanks so much, Salome. I'm going to go ahead and share my screen with these slides. All right, so as Salome mentioned, I'll be speaking about our year 2 interventions.
Yeah, can you put it on slideshow mode, please?
I'll be speaking about our year 2 interventions. So as Fayez mentioned, we conducted some initial formative research exploring each of our 6 priority behaviors. And while we moved forward with design for some of these key behaviors, we also felt that there was some additional work that we needed to do to understand some problems that were a little bit less explored. And one of those problems was around care seeking for children under 5, and specifically the dynamics between providers and clients and caretakers of children under 5 when they do seek care at a health facility. And through our formative research phase, we identified 2 problems that we wanted to further explore. The first is that some providers do not follow quality of care standards, including providing respectful care when treating children under 5 for illness. And the second related problem is that some caretakers do not seek timely care at health facilities when their children under 5 experience symptoms of illness, including malaria, diarrhea, and acute respiratory infections. And so following this problem definition phase, we decided to conduct some additional qualitative exploration of the underlying factors that lead to these 2 problems. And we used a variety of methodologies, including behavioral diagnosis, human-centered design, and community conversations that derive from community capacity building. Some of the areas that we wanted to explore were how do providers prioritize their time on busy days. So we know that providers are really busy, are seeing numerous clients every day. How are they prioritizing their time, and what does their daily schedule look like? How do providers view the link or the trade-offs between providing respectful care and delivering on positive clinical outcomes? So we know that, as I'll talk about, a lot of training and a lot of guidelines focus on clinical care and clinical outcomes. Do providers see a link between providing respectful care and clients experiencing these positive clinical outcomes? We also wanted to find out what feedback providers receive and from whom, and what protocols or guidelines they follow, and what cues they receive to deliver both high quality and respectful care. And then from the family's perspective, we wanted to understand a little bit more about how perceived quality of care affects families' decisions to seek care, and who in the family makes the decision to seek care for an ill child, and what prompts the family to take their child to the health facility. And so we identified a number of factors that contribute to the 2 problems that I identified at the beginning. And we found that there were structural and social barriers for both providers and clients, including a lack of drugs and supplies at the facilities, which are supposed to be free, a shortage of providers, meaning that each provider must see a large number of clients each day, and an evaluation system that pressures providers to see as many clients as possible. And we also found that on the social side, providers tend to give preferential treatment to some clients. And even when they don't give that treatment, preferential treatment, as we'll talk about, clients still perceive there to be some preferential treatment being given because the triage system is not very transparent. Additionally, we found some behavioral factors that influence provider behavior. And first, we found that some providers do not follow quality of care standards, and specifically providing respectful care, because they believe they're already providing high quality care, and they're not cued to consider or change their existing behavior. And by this, I mostly mean that a lot of clinical guidelines that are posted in facilities and that are highlighted in training tend to focus on more clinical care and clinical outcomes. And so providers believe that they're already doing the best job that they can, and so aren't cued to change that behavior. Some providers also choose not to follow respectful care standards because they do not think that they need to do so. And it's not because this is not because they don't care about their clients, but really because they believe that they will be evaluated by both clients and by both the system and their managers on the clinical outcomes and the survival of their patients, and not necessarily on the reception that they give patients or the perceived respect and treatment that they give. The third barrier is that some providers choose not to regularly follow quality of care standards, such as providing respectful care, because they believe the costs of doing so to outweigh the gains. As I mentioned, clients are very focused on the survival of their clients, and providers are incredibly busy and see many clients each day. And so if they believe that some respectful care practices could deter from good clinical outcomes, they may choose not to follow those respectful care practices. For example, we heard many examples of providers scolding or shouting at parents who brought in their children late because they felt that it would encourage parents to bring their children sooner the next time. And this meant that clients were then deterred from seeking care the next time because they were worried about being shouted at. And finally, we found that some providers intend to provide quality care, but they react automatically to emotional triggers. So a health facility is obviously a very high stress environment, especially with busy parents or busy providers and worried parents. And so often parents are incredibly worried about their child's health when they bring their child to the facility, and they might not always act their most rationally or their most happy, and providers tend to view these parents as unreasonable or difficult and don't necessarily empathize with the external reasons that the parent might be upset. So we also looked at this problem from the perspective of caretakers as well. As I said, we found both structural and social factors that impact a parent's decision to seek care, including the very long waiting times at facilities and the long distances that families live from health facilities. We also found that as our design ultimately ended up addressing, clients do not know how to hold health providers accountable. They don't necessarily know what feedback or how to give that feedback to providers or to health facilities. We found some gender dynamics in that men or husbands often control access to the health facility for sick children, and mothers are primarily responsible for both the care of children and they lack family support when a child is sick. We also found that sort of an unintended side effect of a potentially positive intervention, which is encouraging male involvement, meant that providers tend to give preferential treatment to fathers, which can be perceived poorly by some mothers. Additionally, we found some behavioral factors impacting caretakers. We found that to avoid the hassle of going to the facility, which is of course a really big hassle, they must often travel long distances and pay for expensive transportation. Many caretakers delay seeking care until they deem it necessary, but they lack the cues to determine when an illness really is necessary, when they need to seek immediate care. As I mentioned before, some caretakers feel that the triage process is not fair, so they often see providers selecting some clients from the line and taking them ahead of time. And these providers may be doing their job and triaging patients medically, but they do not have the time, or they don't feel like they have the time to explain this triage process to caretakers or parents, and this results in caretakers believing that the system is unfair and that there's preferential treatment. And finally, some caretakers expect certain treatments, certain medical treatments for illnesses, and they're upset when they don't receive that treatment. And we especially heard this around injections. I'm sure it's something that many of you all have heard before as well, is that injections are perceived to be more potent, to be more powerful. They're something that you can't receive at your everyday pharmacy. And so when caretakers do not receive an injection or they do not receive what they perceive to be a strong medication, they're upset about the treatment. So what did we do about these challenges? We created what was essentially a 4-part design, which has 2 distinct components, one specifically focusing on providers and one focusing a bit more on the client side barriers. So the provider behavior change package includes some co-created guidelines for service quality, a client feedback system, and then a system in which providers review the feedback they receive and make a plan to improve. And we'll talk about each of those in more detail. And then our more client-facing intervention is an emergency planning prompt, which both shares the symptoms of illness with parents, but also encourages them to make a plan to seek care in a timely fashion. So the first aspect of the provider behavior change package is a system in which we co-create guidelines for service quality, and in both healthcare facility staff and community members meet to collaboratively develop quality of care guidelines. And so they come together and they say, what would good care look like at this facility? And both providers and clients are given the opportunity to share some of the challenges they face and also what they would like the other party to do. So providers are able to talk about how they would like clients to act, and clients are similarly able to talk about how they would like to be received. The 2 parties come together to create a set of co-created guidelines for service quality, and the guidelines are posted in the facility as a reminder and used as the basis for follow-up for both feedback and reviews. So this is an image of the poster, which is the facilities guidelines for improved child health. And the objectives of this piece of the intervention are to build empathy between service providers and community members, to create guidelines that are meaningful to all stakeholders, and to set shared expectations for provider and client behavior. As I mentioned before, providers aren't often used to being prompted to give respectful care. And so giving them a set of standards to work from and a set of standards that are agreed upon with the community will hopefully encourage them to engage in respectful care as an important piece of quality of care. And these are just some images from our user testing process in which we worked with some folks from the Department of Health Promotion. So you can see a few of our health promotion staff there, as well as partners from Ideas 42 and Think Place, and our Breakthrough Action Field Office as well. The second piece of this intervention is a client feedback system. So I'm sure many of you have, if you are based in Zambia, have seen the suggestion boxes that are often in health facilities. These are often a wooden box, locked wooden box that says suggestion box on it and is often placed in maybe a corner of the health facility, or in one health facility I went to, it was actually behind a tree. So you had to actually go and seek it out. And this is also a place where clients have to actively seek out the feedback box and then give written feedback, even though we know that a lot of our clients in Zambia are not necessarily literate. And so this was intended to create a more salient, more visible feedback system in which once a month, a community-based volunteer collects feedback from clients through this new feedback box. Clients receive a token from the dispensary when they leave, and the community volunteer shows them how to use the box to indicate whether their experience was positive or negative. And then the volunteer also records verbal feedback from the client and puts it into the box. And so clients are prompted when they leave to describe how their experience was, and then to share why that experience was positive or negative. And the objectives of this intervention were to hold providers accountable to providing high quality care, to hold them accountable to those standards that they set with the community, to enable clients to make their voices heard, and to encourage providers and increase motivation through positive feedback. One really important piece of the intervention that we found was actually the positive feedback aspect. Usually the suggestion boxes only tend to have complaints. The suggestions come from people who are motivated enough to seek out the feedback box or the suggestion box and provide negative feedback. And so we found that actually one really motivating factor for providers was understanding the positive perception that most clients have of them. And this made them feel like there were some small things that they could fix in order to have a 100% positive reception. Again, just some images of user testing. And then the final piece is a self-assessment and goal-setting exercise in which the providers actually do something about this feedback. So they review and summarize the feedback and share it in a meeting with all of the health providers. And then they set goals for the next month around what they're going to do better and also what they're already doing well. And so these are just some images of the facility scorecard in which providers describe the feedback that they received in the previous month, talk about one thing that they're proud of and one thing that they'd like to do better, and then set a specific action plan for improving the piece that they would like to do better. We also gave some guidelines for how providers could respond to potentially negative feedback and some suggestions that they could use for their action planning. So all of that piece was the provider behavior change piece. And now I'm going to talk about the client side intervention. And this was, as mentioned up front, an emergency planning prompt. And so this was a very simple intervention in which trained community volunteers facilitated an emergency plan making exercise for parents of children under 5. The plans are then revisited regularly, and especially after instances of delayed care seeking. So you can see the image of the emergency plan on the right in this slide. And at the top of the emergency plan, it indicates symptoms that require immediate care and encourages parents to seek care at either at a facility or through a community health worker. And then at the bottom of the emergency planning prompt, clients are encouraged to make a plan for how they're going to access care in case their child experiences any of these symptoms. So they're encouraged to think through ahead of time who will take the child to the clinic, what kind of transportation will they use to get there, how they will pay for any expenses that might come up, and who will take care of the household while they're gone. And this is a way for parents to come up with a concrete action plan, almost the same way that people in the US or in the West often come up with fire emergency plans in case there's a fire. These are all things that you don't want to have to be thinking about when there's actually an emergency. So we wanted parents to be able to think about potential barriers they might face and how they're going to overcome them before there's an actual emergency. And then at the very bottom of the plan, clients commit to getting help from either a community health worker or a health facility as soon as they see any of the danger signs in the prompt. So this intervention was implemented this year. So it was cut a bit short by COVID, unfortunately, but the project conducted 51 orientations of the emergency plan in 9 districts, 35 health facilities with 445 health providers and community volunteers were oriented through those orientations. And following orientation, just in the first few months of this year, a total of 12,977 emergency plans were developed by caregivers of children under 5. Due to the later implementation date of this work compared to the previous interventions discussed, this intervention was not included in the Breakthrough Research Qualitative Evaluation. So we have a little bit less information about how the innovation was received. And unfortunately, due to COVID-19, the provider behavior change intervention was not able to be implemented this year. And as I mentioned, we don't really have qualitative results of this intervention, but we did do extensive user testing. And so I wanted to share one quick story about the emergency plan from one of the families that used it during the user testing. So this is a quote from a mother. After making an emergency plan, when Frida was inspired to find a box to save coins in, a week and a half later, her child fell ill, and she and her husband rushed to the clinic in a taxi, which she paid for using the money from her savings box. The providers and her husband were impressed with her initiative to save money and to seek care without delay. She shared her experience with her neighbors, who were excited to go to the facility and obtain emergency plans of their own. And this was relayed to us, this is a family in Chingola, and this was relayed to us when we did follow-up interviews with mothers after the user testing of the emergency plans. And that's it for my presentation. Thank you so much.
Thank you so much, Lydia. Great presentation. I'm going to take a couple of questions from the chat. Dawood, would you mind asking your questions? Good to see you online. And I'm going to ask Chime to answer. And if you could tell us where you're from, what country, and what organization, that'd be great too.
Hi, Arzum. This is Dawood. Actually, currently I'm working with Engender Health India, and we deal with a lot of provider behavior change actually.
Great. You had a question about sustainability, I believe.
Yeah. So, like this, in these 3 years, Breakthrough Action has actually done a really commendable job. But what about the sustainability part? Like, whether these best practices are being shared with the government or any other mechanism, so that actually it continues.
Great. Chime, could you answer, please?
Okay. This is Chime. Okay, so good question on sustainability. I think I want to start by saying that from the design of the innovations, the government and some selected implemented partners were actively involved in the design, the pre-testing, the redesigning, and everything, such that even at the time when the project was still being implemented, they were able to implement these innovations on their own. Of course, initially we had to come in. The system that we used, if you look at our guiding principles of the project, we involved the many levels of service delivery of the Ministry of Health, which means including national, provincial, district, and as an SBC project, our focus is at community level. So most of the work we did was with the district, which means that, for example, with the wellness days, if a facility did not have some of the materials they needed, and some of them could be basic, and understandably so, because if on a day they see only 15 adolescents or men, but when you have wellness day, you need more, you see more people, which means for the next wellness days, you have to mobilize resources. So they would do that together with the district health management teams. What is very encouraging to all of us, and we are very sure that most of these innovations are going to be sustained. I'm going to share with you one of the examples which just happened last week. We had a doctor who was working in one of the BA districts. She moved to another district, but because she was trained and she believes in the wellness days, she knows that it's making a difference, especially in the lives of adolescents. She was in a district where there's high school dropouts due to pregnancies and all. So she reached out to us to train her staff in the new district where she's working. And just last week, she got back and informed us that actually Child Fund, as you know, they work with adolescents. They are funding the wellness days. And so they are continuing even without BA. So, and the staff have been trained, so the capacity has been built. We are very sure that most of our activities are going to be sustained. Apart from that, for the IPs that we have been working with, that was the idea. The plan was with them continuing with the innovations even without BA. Thank you.
Thank you, Chime. Another question I'd like to take is from I'm trying to find it again. I'm happy you guys are asking questions. Thank you so much. And as you ask questions, if you could also indicate what country you're coming from and what organization you might be working with. The other question that I want to take right now is from Abisoye in Nigeria. I don't know if she's still on, but I'll ask the question. The question is, how did you get the healthcare workers to commit the extra work occasioned by the increased attendance at the facilities? And were they given any incentives? Fayaz, could you take that question?
Yes, thank you very much. I think this is a very interesting and very valid question, and it has been asked before as well. We were really surprised to see the cooperation of the health workers. And one of the reasons could be what Chimi has explained, that everybody was involved in the design of the intervention. So all of us were keen to see the results, and this included the health facility staff as well. We did not provide any additional support to the health facility staff. The district authorities would sometimes, when they will see there is a greater load of clients, they would bring in staff from other facilities. But that would be done by the district authorities. The same health providers will be providing facilities to all of them, services to all of them. The project had only introduced a very small amount that we would pay in lunch allowance to the staff. And that was it. The rest was dealt by the same health facility staff, all the client service, and nowhere we got a single grudge or complaint or something saying that, you know, the workload has increased, so we need to have more money or something. We did not hear that complaint anywhere.
Thank you, Fayaz. Mary and others have lots of questions about measurement, and we'll take those after the next session. Perhaps we'll touch on some of those during the presentations, and if not, then we'll return back to those questions if you guys can hang on for that. Last question I'd like to take now before we move on was, apologies, about provider behavior change. And I think Dawood had that question as well. It's self-assessment and goal setting is a great intervention. One of the barriers of provider behavior change was filling up forms or any paperwork. Was there any such experiences? If yes, how was this dealt with? Lydia, could you take that question?
Sure, thank you so much. That's a great question. All right, sorry, I hope everyone can hear me. I've just taken my headphones out. That's a great question. So we didn't really experience this problem, but again, we only user tested this intervention. We didn't actually implement it. So I think it could potentially be a sustainability issue, and just want to note that up front. But I think the concern about paperwork is a big one. And I'm happy to share with you afterwards some of the different iterations that we went through with the self-assessment and goal setting exercise. So some of our initial designs were a little bit more labor intensive, more process intensive, and more paperwork intensive. Our final design put most of the onus on the clients to provide the feedback, and then provided a really simple form for providers to come together and fill out the self-assessment and goal setting as a team. We initially had some individual self-assessment, which we thought would potentially be quite impactful, but again, we're worried about the amount of paperwork that it could lead to. So we ultimately settled on having providers come together as a team just once per month and fill out a fairly simple form, which would help them summarize the feedback that they received. So definitely an important concern, and one that, if we are ever able to actually test this intervention in the field, would be one that we'd want to monitor closely. But I think our design tried to minimize that concern as much as possible.
Thank you, Lydia. I think I'd like to move on to the next session, and we'll take some more questions after that one. Now it's my pleasure to introduce to you Mr. Peter Chabwela. And he has been with our project from the beginning as our senior research and monitoring advisor. Peter.
Thank you, Azum, and welcome to everyone. So in this session, we We're going to present the highlights of the mini survey that the project conducted entitled Understanding the Shifts in Knowledge, Attitudes, Practices Around Health in 4 provinces in Zambia as a result of a social and behavior change integrated health project. I have to emphasize that these are highlights. It was quite a detailed study. There are more interesting findings than we are presenting today, and hopefully people are going to actually access the full report. I also have to mention that the research team from the project site is present on this webinar, including the principal investigator, Dr. Carol Underwood, and other investigators, Ruchita, Kahiru, and Alik. And if time allows, they will input into this presentation. Can we go to the next slide? So the study purpose was to serve as a baseline for the intermediate and behavioral indicators of the Breakthrough Action Project, and to also note any preliminary program effects of the health intervention designed and implemented by the project. So this was conducted 6 months after the round of implementation of the 4 prototypes that Fayaz had actually presented on, which was April 2019. A number of the interventions, including the growth monitoring toolkit, came much later than when the other 3 actually commenced. Let's go to the next one. So the study relied on a stratified random sampling design, weighted by population density and balance for urban and rural areas. The sample was stratified by district, catchment areas, and enumeration areas, and then by sex and age of the respondent. The total sample comprised 993 respondents, of which 59% were female and 41% were male. Of the 993 respondents, 298 were adolescents aged 15 to 19 years, 249 were men aged 20 to 55, and 446 were women aged 20 to 49. The study was fielded in the 8 districts and 16 health catchment areas where the project innovations were piloted. And data was also collected on secondary populations, including 5,246 household members and 424 children under the age of 5 years. Let's go to the next slide. So typically for a survey presentation, you would have a lot of background characteristics being presented. This definitely will eat into our time. So we're just going to focus on the characteristics at the household level that perhaps are key to what we're presenting today. So 74% had access to a cell phone or computer, and 50% possessed a means for mobility. Rural respondents and female respondents were less likely to possess technology. For example, 32% of the rural and 11% of the urban respondents didn't have technology in their homes. That is, no radio, no phone, and no computer. Let's go to the next one. Next slide. We'll now look at program exposure and effect as it relates to the innovations that have been presented in the preceding sessions by Fayaz, Lydia, and Salome. Next slide. 51% of male respondents, as can be seen on the screen, and 36% of female respondents who participated in the survey reported seeing, hearing, or reading anything about the Life is Precious, Take Care of It family health campaign. The most common sources where respondents were exposed to the campaign were radio and a health facility or the clinic. Next slide, please. Slightly more male respondents saw the campaign logo in public places, that at 64%, compared to 60% for female respondents. But also more male respondents participated in campaign-related activities at 20% compared to female respondents at 12%. There wasn't much difference between the sexes when it comes to the role in message diffusion. As you can see, it's 22 and 21%. Let's go to the next slide. So to assess program effect, the following variables were further measured. No recall or logo only, that is a family health campaign. Life is precious, take care of it logo, where respondents mentioned not being exposed to the campaign at all, or only mentioned seeing the logo in public spaces. So that's the no recall logo only variable. Then there's the media only variable, which included respondents having heard something on radio or received text messages, seen something on Facebook, heard something on public announcements, or seen something on billboards, posters, flyers, and many more. The third was the face-to-face only, which related to health facility clinic interaction, including wellness days, but also roadshows that Salome talked about, community meetings or events, soccer tournaments, drama performances, and others. And the fourth was a combination of the face-to-face exposure as well as media. Next slide. So in terms of clinic visits, there's some statistics that are not here, but worth noting. About 67% of the respondents reported visiting a health facility in the 6 months prior to the survey. And 40% visited the health facility to receive health services for themselves, and 22% to access services for the child. And as can be seen, participation in media, face-to-face activities, or exposure to both was strongly associated with clinic visits for the respondent. Face-to-face only or exposure to both was also strongly associated with clinic visit for the child. Let's go to the next slide. The study measured satisfaction with while at the clinic, provider interaction, and the client's perception on prejudice and respect. Respondents were quite satisfied with their clinic visits, with close to 90% agreeing or strongly agreeing on all measured aspects of satisfaction. And this was statistically and positively associated with recall of mention of privacy and confidentiality by the health provider. Let's go to the next slide. So for insecticide-treated net use, 64% of the respondents lived in households with at least one mosquito net. And of these, 64% slept under one the night before the survey. Of those that slept under a mosquito net, 98% reported sleeping under an ITN, implying that 2% who slept under an ITN slept under one that was not treated. Let's go to the next slide. The most common reason for non-use or not using mosquito nets was not having enough nets, and that it was too hot to sleep under one at 49% and 26% respectively. Adolescents 15 to 19 years and children aged 6 to 14 years were the least likely to sleep under a net. Let's go to the next slide. Next slide, please. So in terms of program effect on norms around insecticide-treated net use, 62% of men and 56% of women reported that more than half of the people in their communities regularly sleep under an ITN. And in terms of program effects, around ITN use, again, female respondents who have been exposed to either or both media and face-to-face programs were more likely to perceive that more than half of the people in their community regularly sleep under the ITN than those with no recall or the logo only. For male respondent, this applied to face-to-face only and the combination of the two, face-to-face and media exposure. Let's go to the next one. So media-only program exposure resulted in male respondents and female respondents being more likely to report sleeping under a mosquito net the night before the survey compared to those with no exposure or recall. Let's go to the next one. So we'll now look at complementary feeding for children under 2, and we did hear a bit about the intervention that we put in place. So for complementary feeding, and particularly in terms of feeding the child, the recommended number of meals for a particular age group, there was more compliance for children aged 6 to 8 and 9 to 12 months as opposed to children 13 to 23 months that recorded only 37% being fed the recommended 3 meals or more. Recommended diet diversity in terms of recommended food groups for a given age group was generally poor throughout the age groups, with staples being the major fed group, fed to all the age groups the day before the survey. Let's go to the next one. Next slide, please. In terms of background, norms and program effect, mothers or caregivers with higher education were more likely to feed their children. They recommended meal frequency than those at lower education levels. And only 21% of male respondents and 32% of female respondents were of the view that at least half of the families in the communities feed their children under 2 years the recommended number of variety of meals. Among mothers and caregivers, program-related media-only exposure was positively and statistically associated with feeding children the recommended meal frequency and dietary diversity. Let's go to the next slide. So look at care seeking for children under 5 years, and Lydia did give a number of innovations that were designed by the project. A number of these came later on after we studied the implementation of the innovations around care seeking as well. So care seeking for children under 5 that manifest fever, cough, and diarrhea was very high. You got 85% for children with fever, 80% for children with a cough, and 74% for children with diarrhea having their guardians seeking professional medical advice. The health facility or the health provider was the primary source of care seeking advice, and no differences in care seeking were noted by age of children. Next slide. Still on care seeking and looking at norms program effect, 9 out of every 10 respondents reported that care seeking for children under 5 who are ill was a well-established norm. And among the female respondents, face-to-face only, and a combination of face-to-face and media was positively and statistically associated with perceptions regarding care seeking for children with fever or diarrhea. Mothers and caregivers with program-related media only or face-to-face only exposures were slightly more likely than those with no recall or exposure to seek care for their children under 5 for fever, cough, or diarrhea. Let's go to the next slide. Okay, we now go to contraceptive use. And as you can see, 60% of sexually active and non-pregnant population reported using contraceptive methods with injectables. Just click all of them. So with injectables being common among currently and ever married respondents, whereas condoms were the preferred choice for single respondents. Among adolescents and male adolescents, who were actually the key audience for our interventions, at 68% reported being more confident. These are male adolescents, being more confident to obtain contraception than female adolescents. For female adolescents, 100% of married adolescents reported being confident to obtain contraception than their single counterparts. Let's go to the next one. Next slide. Okay, so when we look at condom use, 30% of all sexually active respondents used a condom at last sex, with more male adolescents reporting this than their female counterparts. The 9% of all sexually active respondents so used a condom every time and with a non-regular partner, and female adolescents reported this more at 75% compared to male adolescents at 53%. Let's go to the next slide. So we look at support for contraception access by the respondents. And I'll start by mentioning that 82% of male respondents compared to 53% of female respondents support the idea of unmarried adolescent boys access to contraceptives. Participation in face-to-face activities or exposure to both face-to-face activities and media programs was strongly associated with support for male adolescents' access to contraceptives, including condoms. Let's go to the next one. Next slide. Okay, so in terms of support for unmarried, the previous one, previous slide. Can we go to the previous slide? No, the previous one? It's slide number 22. Slide number 22, yes, thank you. So 73% of male respondents and 40% of female respondents support unmarried adolescent girls to have access to contraceptives. So you can see that both in terms of access to contraception by male adolescents and female adolescents, the female respondents were actually against this compared to the male respondents. And as can be seen, participation in face-to-face activities or exposure to both was strongly associated with support for female adolescent access to contraception, including condoms. We'll go to the next one. So in terms of the norms, female respondents were significantly more likely than male respondents to think that at least half of the people like them in their communities and are family planning users. Male respondents were significantly more likely than female respondents to think that at least half of the people in their communities use condoms. And respondents showed moderate support of the injunctive social norm approving of peer contraceptive use with no statistically significant differences by the sex. The final slide. Okay, so the findings that we presented, and this is indeed in conclusion, they highlight some preliminary effects of the project interventions. And It's also important to note that the survey was fielded in October 2018, before most interventions were fully underway. And as I've mentioned, this mostly the wellness days and then Z that had actually commenced or slightly matured. Therefore, program effects were expected to be minimal, as the survey essentially served to establish benchmarks that the second survey was going to measure against. But as we have heard already, survey 2 was cancelled due to COVID-19 restrictions. But having said that, the extent to which program exposure was associated with intermediate and behavioral outcomes, even at that early stage, demonstrated some promise. These findings support the continuation and expansion of Breakthrough Action Project activities, which have so far led to slight yet positive associations with health promoting attitudes and social norms in several areas. I'm going to end here and thank you so much for your attention. Azum, I can now hand over the meeting to Narupa for the next session on breakthrough research insights. Thank you very much.
Great, thank you, Peter. Welcome, Rupa.
Hi, good afternoon, good morning. Thank you, Arzum. Let me just load my presentation and let me know when you're able to see me. Are you able to view my screen?
Yes, looks good.
Okay, great. Well, hello, my name is Nrupa Jani. Thank you for having me here today to present on behalf of Breakthrough Research. I am with the Population Council. I'm based in our Washington, DC office, and I am here today to present lessons learned from an evaluation of integrated social behavior change programming linked to integrated health services in Zambia on behalf of my other Breakthrough Research colleagues. So a little bit about BR, for those who might not be familiar, as I think was mentioned earlier, we are a USAID's flagship social and behavior change project to drive the generation, packaging, and use of innovative SBC research to inform programming. We are a 5-year project ending in July 2022, and we support USAID headquarters and mission supported activities in close collaboration with our sister project, Breakthrough Action. Now, I won't go into too much detail on this slide, as many of Breakthrough Action Zambia's SBC activities were already discussed in earlier presentations, but we'll mention that Breakthrough Research's evaluation here focused on the adolescent and male wellness days as part of the larger umbrella family health campaign that's been discussed. Now, behavioral insights from the formative research and literature review that Fayaz and others talked about did inform our evaluation. And as was mentioned, the male and adolescent wellness days were one of the 4 design concepts that were developed to promote health service uptake. And that is the subject of our evaluation here, as one of the key findings from the formative research found that men and adolescents were not using HIV testing and family planning at health facilities. Now, the objectives of our study were threefold in informing Breakthrough Action Zambia's implementation of their integrated platform. 1, by exploring the perspectives on and experiences of implementing the adolescent and men's wellness days. 2, to examine the conditions that contribute to the delivery and potential success of the wellness days as part of the integrated SBC programming. And 3, to explore the unintended consequences of integrated SBC programming compared with vertical SBC programming. Our study comprised of 22 key informant interviews with district level health staff, BA Zambia implementing partners, including Society for Family Health and Expanded Church Response, and health facility providers. We collected data in 5 districts listed here: Chembe, Chingola, Chinsali, Itezi Tezi, and Kalalushi. Our interviews were conducted from September to October of last year. They were recorded, transcribed, and then coded and analyzed using thematic content analysis. I'll now present with you some select findings focusing on health provider experiences from the integrated SBC programming of Breakthrough ACTION's Wellness Days. First, we found that behavioral insight research did in fact address practical health issues for both men and adolescents at the Wellness Days. Health providers we spoke to indicated that the health messaging and the materials they provided to clients, along with the condoms and job aid counseling materials, were targeted appropriately and addressed priority health issues. As this quote from a provider in Chembe notes, the health messages are appropriate. The content is also an actual existing problem in the community, so the messages are reaching out to the actual problems, and the IEC materials are also very practical. We also found an increased frequency of care seeking after integrated SBC counseling during the Wellness Days. Health providers mentioned that the integrated SBC messaging incorporated within the Wellness Day counseling materials led to an increase in voluntary health service seeking among both men and adolescents, and also created an enabling environment that reduced stigma, which was a barrier that was indicated in the formative research. Here, a provider in Itezi notes, at least during the Wellness Days, we're seeing men, they're free, they're coming to ask for whatever service they need, like for condoms, even being tested for HIV, even weighing. Some can come just through to say, I've come and checked my blood pressure or my weight, just like that. Similarly, we saw an increased demand for services that were not promoted by the Wellness Days. We spoke to several providers who noted that beneficiaries were requesting commodities and services such as cancer screening, dental care, eye care, and even sometimes stigmatized or misunderstood services like male circumcision. And lastly, we note that adolescents and men require different integrated SBC counseling styles. So some providers noted that adults versus youth and men versus women are at, in fact, different life stages, that is to say physically, cognitively, and socially, and as a result have different risk behaviors that need to be tailored and addressed accordingly. We also found that many health providers requested additional information and coaching for integrated counseling to support different target populations, especially adolescents, as noted here by a provider in Chinsali. A 15-year-old boy would come and ask for condoms. You find that after giving the education, what they're most interested in is carrying the condoms and not really learning about how they're supposed to use it. With them, it's the excitement of getting a condom and going to use it, not really knowing how you're supposed to use it. So, this demonstrates the need to certainly target HIV prevention counseling differently towards adolescents clients versus adult male clients. There are a few limitations to our qualitative study that are worth noting. The first is that we were not able to include the perspectives of Wellness Day beneficiaries, as we mainly spoke to providers and implementing partners and district health staff. And second is that the perceived findings among the adolescents during the Wellness Days could not be disaggregated by gender, unfortunately. So now I will present a few recommendations that we think are useful for SBC programmers implementing multi-health community-based SBC programming with integrated health services. The first is to expand the use of innovative formative research approaches that explore entrenched perceptions and norms that may not be revealed through standard evaluations or surveys. Behavioral insights and human-centered design approaches can, in fact, inform the development of innovative and contextually relevant interventions because of the involvement of their target audiences in the actual design process. Also, participatory approaches such as focus group discussions can also ensure that responses to specific challenges are informed by those who are most directly impacted by them. Next, ensure that provider training focuses on the specific needs of men and adolescents. So expanding the content of existing cascade trainings and dedicating time during refresher trainings to include adolescent-specific and particular health information would be valuable. And additionally, incorporating skills building with role-playing, response mechanisms, counselor training, and discrete life trainings would also be worthwhile. And lastly, consider increasing the availability of facility-based integrated SBC counseling. So we know that successful interventions make clients feel more comfortable to ask for additional services and commodities that might not be included in specific integrated SBC campaigns. Additionally, there are potential positive outcomes from attending integrated services, particularly when gateway behaviors such as HIV testing and counseling can increase the demand for other related services such as male circumcision. And lastly, referral mechanisms should be strengthened so that clients receive immediate and comprehensive care. As we saw in the case of the wellness days, there was much demand for services that were not being provided, and accordingly referrals had been made for those services to clients. I will end by saying, for additional information on our evaluation, I would encourage you all to visit our website, breakthroughactionandresearch.org, where we have recently published a programmatic research brief outlining more details on some of the findings that I have presented today. And I would like to close by acknowledging my breakthrough research colleagues in Zambia as well as in Washington, our Breakthrough Action colleagues in Zambia, as well as in the US, and our USAID colleagues for your support on this evaluation. Thank you very much, and I will close there.
Thank you so much, Peter and Rupa. Those are great presentations. And thank you all for such great engagement in the chat. I will take just a couple of questions now. Mary Hadley has had lots of questions about measurement. So Mary, I'd like to invite you to introduce yourself and maybe ask one or two of your key questions that either Peter, Nirupa, or our other researchers, Ruchita and Carol, might be able to answer.
Yes, thank you very much. Yes, I always have too much to say.
I think it's wonderful. Thank you.
Thank you. So I'm Mary Hadley, Context in Development. I'm based in Kenya, but I worked with the ministry in Zambia at provincial level for about 4 years. So I'm very familiar with the Zambian ministry and the health systems and how the systems are working there. So I think overall an evaluation, in some ways, it's a bit early to say that this was a success. And yet, on the other hand, you're probably understating the importance of the achievements that you made. You had a lot more clients. We're talking about thousands more clients, which means a huge extra workload for staff. Some of them are not taxed, they're not fully occupied the whole time. Others are, depends on the facilities. But the positive outcomes then could lead to a lower workload if malaria is reduced, if AIDS is reduced, if PAC deliveries, malnutrition, if all that is reduced through those wellness days. I think that will balance out beautifully. You'll and as well for the community impact. And I don't think it's too early to be able to measure these. The DHMTs, they all have access to DHS2. It will be very easy, DHS2. It's very easy for them to monitor the effects. If the girls walk away with condoms or are on family planning, they understand about family planning. The teenage pregnancies should go down. I was wondering how many of the HIV tests were positive out of 4,000, over 4,000. Any of those who are put onto ARVs will mean that the transmission is stopped. So, I mean, I don't think it's too early. I think you can just get hold of the DHS in a week. You can find this out, and better that the DHMCs do it themselves because they know how to analyze their data and manipulate it. And then they will also be, you know, much more interested in continuing these wellness days, which need to be included in their annual plans and their budgets and whatever, if resources are needed. And then in general, the social media listening, if that is introduced, I think this is a great new technology where you start looking at Facebook, not WhatsApp, unfortunately, but Facebook and Twitter, and see what people are saying. You might notice that you have changed attitudes by the way people are talking about family planning. They start to talk about it more in different ways. They're not afraid, they've got condoms, they're using them. Yeah, I'll stop talking.
Thank you. Does anyone from our research team have any contributions?
I think I can start. Yes, so I think it's an important observation, and it is something that I think Caro or Ruchita actually going to confirm that consideration was made much earlier in terms of what our data sources are going to be for our indicators at all levels of what represented in the PMP. And yes, HMIS, DHIS2 is one of the data source for some of the indicators. There was also the Zambia Demographic Health Survey, which we did consult. It came out a bit late, but nonetheless, it did become useful. But then I think the question around the wellness days and I think the early promising results is also something that we did document. As an example, when the wellness days commenced, we conducted an analysis of the attendance indicators as well as the service access indicators for 2 quarters, January to March 2019, which was before the wellness days, as well as April to June, which was 3 months after, or within 3 months after the wellness days had actually commenced. And this is something that we thought we were going to do again this year, but I think in the middle of doing this, we have had to call our staff back because of the complication around COVID-19. So for example, for the analysis that we conducted in 2019, when we look at main attendance, and this was done in 13 facilities out of the 16 pilot facilities, because the others we had challenges accessing clinic data. So for main attendance, for example, we noted a 19% increase in terms of attendance to the clinic. This is usual clinic and not a wellness day clinic. Adolescent attendance increased by 68%. And then there was also 32% increase in terms of family planning new acceptance. So this is just to give an example of what the early analysis looked like when we actually conducted it. But it's something that, as I've said, we had hoped that we're going to continue doing this. So yes, it is an important observation, and it is something that we can perhaps highlight more.
I just want to add, Peter mentioning those indicators, we did add those outcomes to our PMP and we were tracking them. We did mention them with the caveat that we can only say that we indirectly are responsible for those changes. We don't have questions added that directly connect our programming to those outcomes directly. So while we can track them over time and we can attribute some of those changes to our programs, we can't make that direct link. Our mini survey, however, as you've seen, has shown some preliminary effects. So we can be confident in saying that. We have tons of data from the wellness days, exit interviews, provider interviews, that do confirm that behaviors around care seeking have improved in terms of outcomes. We haven't done any tracking at the community level. We were hoping to do another mini survey, but due to COVID, we weren't able to do that. Otherwise, we would have had a secondary and possibly a third data point that would have shown some trends.
Thank you so much. All right, I think we can move along to our next session, where we'll be sharing some voices from the field. So it's my pleasure to introduce my colleague, Uttara Bharat Kumar, and Uttara is our Senior Program Officer, who's also on our capacity strengthening team and has been a big part of the Breakthrough ACTION Zambia project. Uttara? Oh, we can't hear you, Uttara.
Can you hear me
Oh,
now?
there you are. Yes, we can hear you now.
Fantastic. Okay, hi everybody, and I think I have the happiest task of all here because I get to share with you the fun things that people have said, and it's in many cultures. I think the validity or the effectiveness of something is measured by how others see it. And it's my pleasure to sort of share with you some of the breakthrough action voices from the field to tell you in their own words what they felt or thought about the program. So I'm going to share the screen, and I'm going to hope that the sound is going to work well. Can you see the screen?
Yes.
Okay, great. So let's see. I'm going to start here.
Muliudi, mulishani mkwai, mulibuti, tambukeni mwane, mutende mwetu kwasu. Good day. My name is Amos Imbulo, Chief Shaibila of the Rala people of Bukoshi district. I'm a father, a husband, a retired bank manager, and now a traditional leader. My chiefdom is vast. I preside over a population of 70,000 people with the support of 10 senior headmen, 80 headmen, and 150 sub-headmen we call Sultani. As a traditional leader, I want to see a happy and prosperous community, a vision which can only be accomplished if families and communities are taking care of their health. I've taken a bold step of banning traditional healers in my chiefdom because I want people to access health services from health facilities. I also encourage my people to support the Ministry of Health by contributing at least one bag of maize or soya beans after each harvest to generate resources for the construction of clinics and health posts in their communities. When I talk to people, I talk about simple steps for a good life: eating nutritious food, sleeping under a treated mosquito net, avoiding risk sex, consulting health providers if something is wrong, and many small things like that. Is it a big ask to enjoy good health? No. We all know life is a precious gift and we need to take care of it. Thank you.
So some of the other things that we've heard from the field, and I'm going to play a few videos in this session just so you can hear it from people's own voices, but some quotations that may enhance and supplement what you've seen in the presentation so far. During this visit, I was attended to by a kind health provider who counseled me on a number of health issues, including family planning. I decided to accept family planning for the first time after the counseling session. I'm so lucky that I didn't fall pregnant and I'm able to continue with my school because I was on family planning. Mercy said, it saved my future. I feel sorry for my friend who's now pregnant and out of school. These are participants of Adolescent Wellness Days in Chembe in Lopula district. So these are real quotations from folks in the field. I was able to freely choose a family planning method of my choice after recently attending a Wellness Day event. I didn't feel like the health worker was judging me. I felt like she was supportive and kind. This is an adolescent from a Wellness Day in Ndola. I brought her to the facility for this day meant for young people because I suspected that she could be pregnant because boys in our village take advantage of her illness. Since she's not pregnant, I discussed with her and the health provider the need to initiate her on family planning because pregnancy is risky in her state. This is the mother of an adolescent girl with a disabled adolescent girl in Chembe. From a men's wellness day, I thought having a big body is a sign of good health, but I was proved wrong today after the clinician took my weight, height, and body mass index and told me that I was on the heavier side and I need to reduce my weight. A man who came to a wellness day in Mukushi and subsequently had access to all of the other services around HIV, family planning, and malaria as well as counseling about child feeding. Like most men in Zambia, I only go to the clinic when I'm sick. I didn't know that I could visit the clinic even when I'm not sick. A participant from a wellness day in Mukushi as well. A provincial health promotion officer in Copperbelt province says, it was gratifying and exciting to note that there was an increase in the uptake of family planning services among adolescents. A review of data at the 2 Breakthrough Action supported facilities in Kalulushi showed the number of new family planning acceptors among adolescents had tripled. And Reverend Jacob Banda, a member of the Religious Leaders Network, says, I want to lead a church that is well-informed and healthy. We hear now from Mercy Mulwanda, a Senior Health Promotion Officer from Mukushi District in Central Province.
I am Mercy Mulwanda Chisi, the District Health Promotions and Education Officer for Mukushi District, Central Province, Zambia. I worked closely with the Breakthrough Action Zambia in implementing the 4 main interventions, which included the Men's Wellness Days, Adolescent Wellness Days, Complementary Feeding for the under 2 years, and the Emergence Plan for the under 5 years. As a district, we recorded very successful outcome results in all the 4 interventions. And as a way of sustaining the gains end, we have agreed as a district that we are going to own these interventions by integrating them into our routine services. So for Adolescent Wellness Days, it will be integrated into the adolescent-friendly spaces as one of the activities. And for the Men's Wellness Days, each health facility have agreed to come up with a specific day when men will know that this is their day and they'll still access these services. Then for the complementary feeding for the under 2 years and the emergence plan for the under 5 years, they're going to be integrated into the routine clinics for child health programs, like the under 5 clinics and the antenatal clinics, and also the postnatal clinics, both static and outreach. On behalf of the District Health Director, Dr. Lusali, I would like to really appreciate Breakthrough Action for the support that they gave us as a district, because we have learned a lot. And the stakeholders, the community, and all the health facilities are very happy with the results. Thank you very much.
Thank you, Mercy. And our next video is from Nelson Waitolo, a Provincial Health Promotion Officer from Copperbelt Province.
My name is Nelson Waitolo. I'm the Senior Health Promotions Officer for Copperbelt Province, the Provincial Health Office. Basically, I want to just briefly talk about what Breakthrough Action has been doing on the Copper Belt. Basically, they've been trying to increase adoption of health behaviors and the maintenance thereof for HIV, maternal child health, family planning, malaria, and nutrition. One of the critical or landmark activity that Breakthrough did on the Copper Belt in trying to increase the adoption of this behavior is the wellness days. I think the wellness days in all the supported districts happened, and I think we could see the increase in access to HIV services by both adolescents and men, and we saw an increase in access in malaria services, that is preventive and curative. My name is Nelson Waitolo.
Now we're hearing from Wangala Chibabuka, Chief of Party for the Zambia Family Activity Project of ECR.
I'm Wangala Chibabuka. I work with Expanded Church Response as the Chief of Party for the USAID-funded Copper Belt Lusaka Zambia Family Activity, a program supporting orphans and vulnerable children. Would like to extend our sincere gratitude to Johns Hopkins Center for Communications Program through the Breakthrough Action Program for partnering with Expanded Church Response to implement the Complementary Feeding Program for children below the age of 2. Breakthrough Action Program provided Expanded Church Response with the technical support and helped Expanded Church Response to develop the human-centered social behavior change growth monitoring toolkit to empower the primary caregivers of children below the age of 2 to track the growth of their children at home, as well as to improve the child feeding practices. Through this partnership, 156 Chitenge growth monitoring charts, 200 feeding bowls, and 200 booklets were distributed in the OVC households with children below the age of 2 in the 10 Zamfam districts. The project also trained 34 local health facility nutritionists, 2,710 community volunteers in the use of the toolkit so that they could support the households with children below the age of 2, as well as facilitate the referral process from the community to the facility, as this would guarantee project sustainability. Thank you, Breakthrough Action, for adding value to the nutrition services that are provided by Expanded Church Response.
And finally, we hear from Dr. Mutinta Mudenda Chilufya, who's the Acting Director, Ministry of Health, National Malaria Elimination Center.
I wish to take this opportunity to thank the President's Malaria Initiative for the support they have rendered to the Zambian government through the Malaria Elimination Program. They have been an all-weather partner, and for that we're grateful. In this particular instance, I want to thank them for the help rendered through Breakthrough Action. As a malaria program, we have a strategic plan outlining how we want to eliminate malaria, and we have identified the high impact interventions. These include IRS, long-lasting insecticide-treated bed nets, and prompt diagnosis and treatment of all malaria cases. Now, no matter how good our interventions, if the people for whom they are targeted do not take them up, we are not going to eliminate malaria. Hence the key role of social behavior change communication. And it is in this role that the Breakthrough Action have come through for us. We have worked together on a number of activities, such as the development of key messages for those areas that have been problematic in terms of uptake of malaria interventions. We have worked together to come up with a new malaria theme song that will be used in all malaria advertising. They have been key as we've been planning for the about to happen long-lasting insecticide-treated bed net campaign to come up with messages of how we're going to utilize the nets, what to do if the net is worn out. I wish to take this to do if the net is worn out.
So thank you very much for all the folks who took time to send in their videos. And, you know, in an era where we're all on Zoom calls and it's difficult to have in-person delivery of testimonials, we really appreciate people who sent in their thoughts and comments when we reached out to them, and were very generous with their time and technology, went through their technology challenges and managed to get the videos to us. I'd like to end on a high note and share one last video with you, and before handing back to our Zoom.
Hello, my name is Pastor Bernard Handavide Hanamwaza from Chakanga village in Chembe district. I am a husband, a father, a pastor, and a volunteer community health worker. In 2011, while living in Ndola district, I witnessed a prominent businessman die from malaria because his pastor had advised him to pray instead of taking medication. That tragedy made me realize the important role I, as a pastor, could play in the well-being of people. Since that day, I have served on various platforms supporting the Ministry of Health to empower individuals, families, and communities to prevent diseases and seek health services when needed. I'm in a committee which looks at issues of health for district level, Ministry of Health. I often advise people that prayer is important, but we also need to do our part through good, healthy practices every day. Like many of us, my happiness comes from seeing my family and community living healthy and happy lives. Living a healthy life is possible through small and simple steps that all of us can easily take. Steps such as planning and spacing your children, sleeping under treated mosquito bed nets all year long, testing for HIV, and adhering to treatment if HIV positive, and many other simple things that can give us big rewards. And I remind people everywhere I go that life is a precious gift of God. We need to take care of it.
So yes, life is precious. Let's take care of it. Thanks for everybody for their testimonials. And it has truly been a pleasure and an honor to be part of this project. Our Zoom, handing back to you.
Thank you, Ujira. Thank you, everybody. Before I move on to closing this dissemination event, I think we have time for maybe one question. If there's a burning question from one of the participants, you can raise your hand and we can acknowledge you. We've been doing some answering of questions in the chat, so I think you should refer to those as well. Anyone have anything they would like to add? Okay, I don't see any hands. So thank you. And Justin, could you pull up the final set of slides for me, please? Great. So thank you to the nearly, well, 70 of you that have stuck with us over the past almost 2 hours. I want to take another few minutes to discuss where the project materials will be archived and how you might be able to access them. As you've heard, we've had dissemination meetings in each of the provinces, and the packages of materials have been handed over to the relevant officials. And we're in the final stages of archiving the project materials on the Zambia Compass. Some of you may have heard of Compass, and perhaps some of you may not be as familiar, but the Compass is a curated collection of social and behavior change resources. And the collection offers the highest quality how-to tools and packages of materials from various SBC projects. Each item in the Compass is vetted to ensure it was developed via a strategic process and had some documented success in the field. So the Compass is designed to help SBC professionals improve their work by providing practical resources, including these how-to guides that I mentioned, which are step-by-step instructions on how to perform fundamental SBC tasks. There are trending topics, which are collections of 20 or 30 resources on hot topics of the moment. Spotlights are real-life examples of how successful SBC programs and campaigns were designed, implemented, and evaluated. And then there's a variety of SBC project materials and resources. So Compass users are invited to upload their own resources to the collection that are then reviewed to ensure that they meet those two criteria, that it was created using a strategic process, and there's some documentation of positive results, whether it's evaluation reports or success stories or case studies or any broader adaptation or scale up. So the Zambia Compass is a Zambia specific site that has Zambia materials, but also links to what we call the global Compass for SBC as well. So if you go to the next slide, Justin, we'll see that this is the web link for the Zambia Compass, but you can also get there from the main Compass for SBC.org as well. So we encourage you to explore the Compass and also become a part of the Springboard online community of SBC professionals. And if you go on the Compass on this website, you'll see how to become a member of that community as well, which is a great place where you can network with other SBC professionals and get advice, participate in online chats about important work that's being done. So it's really, I encourage you, if you're interested in social behavior change, to really become a part of our community. As Dr. Caballo and Chime mentioned earlier, we're confident that the work of Breakthrough Action Zambia will continue and sustain after the project ends. Chime gave an example of someone who was trained in one community or district moving to another and wanting to have the same interventions happen in that community. And that really is a testament to the commitment and the passion of the providers and the Ministry of Health in Zambia. And we really appreciate their partnership over these last few years. So I'd like to appreciate and express our deep appreciation for the Breakthrough Action Zambia team, both in country and in Baltimore and Washington and around other places in the US now as we're scattered during this COVID-19 pandemic. It's been a true pleasure working with each of you. And I think today's presentations are a testament to the passion, dedication, and hard work that really underlies all of this work. I'd like to also pass on the appreciation of Elizabeth Solomitos, who's the project director for Breakthrough Action. And she had to jump off this webinar, but she also sends her appreciation and congratulations for her job well done. At the end of this webinar in the next couple of days, we will send out a link to the recording. And we'll also, once the materials are all uploaded on Compass, we'll be sure and let you know about that as well. So you can see the dissemination packages and hopefully take them and adapt them for your own use. And last but not least, I'd like to thank USAID and the American people for their generosity in supporting this project, and the Zambia Ministry of Health for their partnership. And we hope that we've been able to make a positive difference in the lives of Zambian families. And we know that all of you will work to keep this momentum going. So if there are no further comments, I'd like to say thank you. And until we meet again. Zikomo. Anyone else? Fantastic. We'll see you soon. Bye.
Thank you.